Good morning, everyone. This is week 1, Family Day, and just a couple quick words of introduction for the new folks. Family Day is a super important part of pain rehab. Pain rehab is a confusing, hard work, kind of counterintuitive process that we have our patients go through for 3 weeks. We feel like it's important to explain it as best we can to families and friends so that you can be a good support for the people going through the program. And so there's 2 parts to Family Day. This morning we will be together, folks in the program and family members. After this group we'll meet with the family members and the family members from the other group in the family only part. Every week we review on Friday some topics that we've talked about throughout the week. And we tend to pick on sort of 3 main topics. This week the main topic is central sensitization. Next week is cycle of pain, and the following week is pain behaviors. And we've set aside those 3 major topics, and we're covering them every 3 weeks, because if you understand and can grasp the importance of those 3 central topics, all of the rest of the work of pain rehab sort of falls under those general areas. Couple of other words just for perspective. Pain rehab, as we practice it here, is not a new concept. Mayo Clinic has had a continuously running pain rehab program since 1974, okay? So this wasn't something we cooked up at Denny's over a couple pots of coffee one night and thought it would be a good idea, all right? And the reason I mention that is many people come in and say, I've never heard of this before. What is this? Why did I not hear about it before? I don't know why you never heard about it, but we've been around for a long time. So this is a well-established treatment protocol. There's nothing experimental about it. It's very, very effective. But there's a couple of principles that are difficult. Number 1, all of the progress and effectiveness relies on our patients' participation. We don't do anything to our patients. We help our patients do more for themselves. A second principle, and I will repeat this a lot during the 3 weeks, pain rehab is all about improving function. It is not about reducing symptoms, okay? And you'll see this morning why that's such an important concept, but improving function allows the person to have less symptoms over time, or the possibility of less symptoms, but it has to start out with functioning better. All of the rest of medicine focuses on helping you feel better to function better. And if that had worked, you would not be sitting in this room this morning, okay? But the feel better to function better is ultimately a losing proposition when chronic pain and symptoms have set into the body, as we'll talk about this morning. So we lead with functioning, not feeling. Secondly, it's a slow and arduous process. This doesn't happen overnight. It takes 3 weeks to even begin the process, but the progress can continue for a long time going forward. So this morning I'm going to review 3 related things, and we'll tie them all together by the end, with the pivot point being central sensitization. Before I start that, though, I do want to take a moment and discuss a topic that we talk about a lot in the program. We call this the versions of our patient. And one of the concepts that we operate under is that people coming into pain rehab have been busy and active people. People coming into pain rehab are sick and tired of being sick and tired. They're tired of the limitations. They're tired of their life not being at a high quality and high level. And part of that conflict, that lack of feeling settled is because y'all did stuff before your symptoms. And so we've kind of conceptualized this in the versions of our patients. So before symptoms, our patients were active, productive, social, physically fit, might have been the go-to person, but had independence, could make plans and follow through with plans, could achieve goals, could get work done, could be active with families and friends, enjoyed activities of different types. And all of that, as we'll talk about this morning, changed with the onset of central sensitization, and now the version that comes to the program is someone that might be prone to pushing and crashing, deconditioned, depressed, medicated, socially isolated, largely dependent, either dependent on medicines, dependent on rest, dependent on other people, but the quality of life has diminished and the dependency has increased. And during the 3 weeks of the pain rehab program, we're working to improve activity, improve mood, improve social functioning, improve independence. But we have to add in stable, moderate, and flexible. Let me briefly discuss these concepts. In your A version, you didn't really need stability, flexibility, or moderation. You could just charge on through, get stuff done. If there was a challenge, you overcame the challenge. You just did life. In the B version, it's just reacting. It's just trying to feel better. It's like trying to find anything to help your situation. And over time, whatever behaviors and whatever treatments and whatever medicines you took actually diminished your functions. We'll talk about that in a minute. And so life became very different. I do not ever want to imply, though, that you became a different person. Fundamentally, all of our patients are the same person inside. This implies their ability to do life was diminished. The stability, the predictability, the functionality was lost. And the reason we do this model every week is it applies to so many different parts of the program. This applies to goal setting. In your A version, set a goal, met a goal. In your B version, what goal? Oh, get dressed today. Your C version, we want you to start thinking about goals again because you can achieve them. This applies to social interactions. In your A version, no big deal to go out for dinner. In your B version, I'm not going out to dinner. Your C version is, let's go out to dinner, but stay not as long or something. So it's all about adaptation with an eye towards these three things. One other core principle that is super important is there is no returning back to the A version. It's gone, okay? People hear that the first few times and they get a little misty-eyed and they think, what are you saying? I'm saying there's no going back to the A version. You can't be fixed. There is no fixing what has happened with central sensitization. But there is managing. There is adapting. There is behaving differently. And when you behave differently and you adapt differently, life can be amazing. The C version, I could tell you story after story. We could spend the rest of today talking about graduate success stories. The C version can be really, really awesome. But it can only be obtained by this specific pathway. You can't just jump there. You can't just wish it were to happen. There's no pill to make it happen. It's the hard work of pain rehab. And once you get to the C version, there really is no limits to the improvements that can be made, but it takes a continued application of PRC principles. And family members, the reason I review this on Family Day is because I want you to help us change expectations. I don't want family members to say, I just want my old so-and-so back. Wouldn't it be great if you were just like things used to be? You're putting undue expectations, undue pressure on the person, accept the C version. It will be very good. I'll let you know one last little thing before we move on. A lot of our graduates have said they are nicer people in their C versions, because sometimes in your A version you could have been a bit of an a-hole, okay? And in your C version you're more patient, you might be more tolerant, you have a different perspective while you're getting back to life. So it's a very, very promising prospect. So with that as kind of a backdrop, I want to talk about another set of definitions, acute and chronic. An acute medical situation, by definition, would be time limited, onset known, cause known, treatments work, and tissue damage and symptoms correlate. A broken ankle is a good example. You fall down and break your ankle, you hear the snap, it swells up, you can't walk on it, the x-rays show that that's the broken ankle, you go to the emergency department, they give you some pain pills and a cast. That fits an acute problem very well. We know what happened, we know where the problem is, we know what to do about the problem, and the problem will resolve itself with proper treatment. And a whole list of medical problems could fall under this acute title. Even some cancers would fall under this, because you know what to do about them, you administer the right treatment, and the person can be put in remission from the cancer. This is where we love medicine, because we love the fact that things can be fixed. And in fact, this is where most of medicine lives. This is our culture of Western medicine. We can fix things. Heart transplants, chemotherapies, administering other fixes, so to speak. The problem is that once this transition has happened, now the problem is long-lasting, permanent, if you will. The onset of when it became chronic and what caused it to be chronic is less clear. Treatments become very plus-minus. And tissue damage and symptoms don't match up anymore. That ankle still hurts 3 years later. There's no more casting it. The MRI imaging will look normal, but the person's like, it still feels like it's broken. That's the quandary, that's the conundrum that we've been in for a long time. That's what central sensitization helps explain why that happens, which I'm coming to in just a moment. Two other points about this. This is not an issue of acute versus chronic, okay? This is not two very different things. This is an issue of acute becomes chronic, and some other things change. Generally, there's good social support for someone that's in an acute medical situation. People bring you casseroles, and they bring your groceries, and they give you get well cards and flowers and well wishes. And it's going to be over pretty soon. So people are kind of rally behind you. As many of you can attest, social support over here gets kind of sketchy. And family members, you don't have to nod because you'll incriminate yourselves, but you don't know whether to pat them on the head or kick them in the behind sometimes. You don't know how to react anymore. And folks going through the program, you don't know what you want. Do you want them to not say anything? Do you want them to say they're sorry? I mean, it just becomes a very dicey prospect. And the last thing is life impact. In the grand scheme of things, an acute medical problem doesn't forever change the trajectory of someone's life. You heal, get back to things. There's an expected return to life. But over here, there's a huge impact. This is disruptive. This is life-altering. This is top to bottom, just changes everything. And how do we know that? I'll tell you the most simple behavioral cue of all. Who would spend 3 weeks with us if it wasn't a big deal? right? If things were going fine, you would not take 3 weeks out of your life, come to Jacksonville, Florida, and listen to us. Your lives have been disrupted. That's why you're here. So we know this from top to bottom. It changes everything. So let's go to the model. The rest of our focus this morning will be on the nervous system. And we spend a lot of time in our groups together talking about the nervous system, the human nervous system. And it's divided generally into two components, central and peripheral. Central, brain and spinal cord. Peripheral is sensory, motor, autonomic. And so both the peripheral, the stuff in our body, and the central aspects of our nervous system are implicated and important in this concept of central sensitization. So let's start in the body with the sensory element. Every square inch of our body has sensors in them that send different information to the brain. All of the usual suspects, all of your sensory experiences, vision, taste, hearing, smell, touch, have sensors in them. But we also have sensors in our digestive system. We have sensors in our balance system. Our nerves and blood vessels have sensors around them. All of these neurons, these tiny little cells, are there to send a message back to the brain. And they're there to do just one job. In the back of your eyes, you have photoreceptors that are there to transmit a signal if it's stimulated by a specific wavelength of light. In your inner ear, you have hair cells that respond to specific wavelengths of sound. Your skin, receptors for pressure and temperature and movement. Our digestive system, all of our systems have these sensors. And sensitization of those sensors isn't always bad. Your preference for certain foods or drinks are based on sensitization to a degree. Coffee, I use coffee frequently, coffee drinking. Your first cup of coffee, whenever that was hot bitterness. And you put sugar and milk in it and try to act like a grown-up. But now, if you've been drinking coffee for a number of years, you can say, you know what, I really like the Starbucks Sumatra, and you can get kind of specific with your taste. That's sensitization. My grandmother had sensitization in her fingertips for needlework. She could make stitches look like a machine did them because over the years, her fingertips got sensitized to thread pressure. Just knew exactly how much pressure to put on. So it's not always a bad thing, but what we're going to talk about for the rest of our time this morning is when this becomes noxious or uncomfortable, what the consequences are. So let me explain, at least in a beginning way, how this can occur. If I were to tap on my hand with the pen, all I'm sensing right now is a tapping sensation in that part of my skin. That's what my brain's picking up. When I stop tapping, sensation goes away. If I were to tap long enough, I could begin to experience what's called neuromodulation. That is, after I stop tapping, I might feel tapping for a little bit of time and then it would fade away, okay? We have all experienced neuromodulation. If you've ever been on a boat and you got off the boat and you're on dry land and you still feel like you're going up and down for a little bit, or an amusement park ride and you still feel like you're spinning around. The neurons talk for a minute and then they quiet down and go away. That's normal. But what happens after that is if I were to tap on this much longer, I could develop neuroplasticity. That would be now my neurons send that signal all the time, whether there's tapping or not. That's the first part of sensitization, the change in the receptors. And some of our patients have that where their symptoms are always there, sometimes louder, sometimes softer. We have other versions of neuroplasticity where the symptoms might come and go, but now more things cause the symptoms. So now not just tapping, but if I wash my hands or move my hand, I might get symptoms. That's what some of you experience. So it starts in the body wherever the process is initiated. And then we end up with an upregulated signal traveling via the spinal cord to the somatosensory cortex that gets sensitized. And it's important to understand that the somatosensory cortex is organized by body part. There is specific representation on this patch of neurons in your brain according to your body parts. And the reason that concept is important is that this accounts for the spread of symptoms. This accounts for why a person might injure their right hand, and over time their right arm might begin to hurt, and then their left arm might begin to hurt. This accounts for why one part of the digestive system might be impacted and now pain can seemingly move to other parts. It also accounts, once the whole pathway gets sensitized, for randomness. Some of our patients have what I call popcorn symptoms. You know, they'll wake up one day and they'll feel pain in their left shoulder, and the next day it'll be their abdomen, and the next day it'll be something else. And it popcorns around. Other folks come in and they have one spot, and it's always in that spot, and it's always the same symptom. But in either case, the brain has now changed its reactivity to those signals. And the consequence of that change is symptoms can worsen and proliferate. Pain, fatigue, nausea, feeling dizzy, numbness, tingling, etc. Now we have a proliferation of symptoms that gets worse, they can spread, they can multiply. And secondly, we get a proliferation of triggers. Now things like light, sound, smell, taste. What's that? Yeah. Taste, touch, temperature, movement. Now all kinds of things can trigger it. And we're going to talk next week about this, but this phenomenon is what leads you to all the ologists. Because you go to your doctor and you start talking about all these symptoms and how it's bothering you and different things are impacted, you're going to end up in ophthalmology, neurology, rheumatology, gastroenterology. Just the list is endless. And once you enter the world of specialized medicine with this kind of problem, they start dissecting you into your subparts. It's not very good for your health, okay? We talked earlier this week, a narrow medical focus will find that which should be missed and miss that which should be found. We can find anomalies, we can find pathology, we can find lesions, but sometimes going after those lesions makes the problem worse and not better. We have another saying, there's not a pain problem another surgery can't make worse. You keep invading the body with scalpel and probe and laser, you're going to leave behind scar tissue and cut nerves and potentially make this worse. So this is a real dilemma at this point in time. And there's two implications. Implication number one, there's no psychology here. This is not a psychological problem. This is not psychosomatics. This is not somatization. This is not a conversion disorder. This is not hypochondriasis. This is not just you wanting attention. There's no such thing as secondary gain. There's only primary gain, but we'll talk about that in another class. There is no psychology. A person cannot do this to themselves. And just quick side note, just thinking logically, humans want comfort and control. That's kind of our primary drivers. If you did this to yourself, let's just say for a moment you could, if you did this to yourself, how's that working out for you? More comfortable and more in control? No. Life is more chaotic and more out of control. Bad move? You can't do it, but if you could, you'd either be crazy or dumb. There's no psychology here. Did I say that already? There's no psychology here. If you're watching this on video, there's no psychology here. So get off the psychosomatic train. Secondly, there's no more room for physical interventions. Where are you going to stop this? Are you going to go back into the body and unsensitize the sensors? No, you can't. Patches and creams and acupuncture needles and massage and whatever else, that's not going to do anything to turn this system off. Are you going to intervene at the spinal cord? Yeah, you can block stuff for a little while, an injection, a stimulator, etc. But it's not, the body's going to adapt and work around it eventually. What are you going to do in the brain? Nothing. There's no pill that affects this area. The only thing that turns us off is general anesthesia. And then you're a potted plant and we have to turn you every so often. So there's no pill intervention, there's no physical or manual intervention, there's no surgery that's going to stop it. This has become a chaotic sensory fire. And we'll talk a lot about that in the different weeks that we have the program, but that's the core issue here. There's no psychology, okay, that's cool, but there's also no more room for any physical intervention because you can't turn this off. Now before I move on to sort of the what do we do about it, I do want to talk really briefly about cause. A lot of people ask, well, what causes this? What does the science say? And the answer right now is we don't 100% know, okay? There are some theories out there. One of the theories is that many folks with central sensitization might have kindled for a while, that is, had some subthreshold issues, maybe had a little bit of this and a little bit of that, and then one event turned it on, like a surgery or an accident or a sickness. Had lots of patients over the years that would say, you know, I kind of always had a little this and a little that, but then I got the worst case of the flu ever, and after that, I was just off to the races. Had lots of patients say, you know what, I went in for this surgery, thought it'd be pretty routine, and I woke up and the pain was just out of control and it's just never stopped. Then there are the people that have just a slowly building problem, like headache patients. Yeah, I used to have migraines every so often, now I have them every day, and I don't know why. So the cause is still elusive, it's not 100% pinned down, but I want to put this in the context of diagnosing, because coming out of the medical model, you guys have been given plenty of diagnoses, and I want to just clarify the role of that. And so we talk about the fact that there are three general categories of diagnoses. There are syndromes, damage, and disease. So a syndrome is a reliable cluster of symptoms that can be diagnosed person to person. So specialists get together and they develop diagnostic criteria for certain syndromes. All of the headaches that are diagnosed are syndromes. The neurologist or the physician will ask you your symptoms and they'll put it together and say you have a common migraine with aura, or you have this or you have that. All syndromes. And what a syndrome means is you have something, but it's not going to kill you. Fibromyalgia is a syndrome. It's a real thing. It's a real medical condition, but it's not going to kill you. No one has ever died from fibromyalgia. So some folks come in being diagnosed with syndromes. You rule out other things and then you call it this condition. Some come in with damage. Tissue has been deranged and damaged from a surgery or an accident or whatever. The damaged group, the tissues have healed as best they can, like my 3-year-old broken ankle example. The tissues have healed, there's no more tissue healing to occur, but the symptoms still fire off from wherever the damage was, okay? The last group are people that have diseases. Diseases are life-limiting or potentially life-limiting conditions that a person could die from the complications of. Diabetes, heart disease, Crohn's disease, things like that. You could die from that. But our patients are not here for their diagnoses. Whatever categories you fall into, one or many, you're here because of the impact. You're here because of the impact of your medical condition, not the medical condition itself. And that is why we can lump people with so many varied medical histories in the same program. We can have people that have had damage to their body sitting right next to somebody with fibromyalgia, sitting right next to somebody with diabetic neuropathy, and it works for everyone. because you're here for the impact, the consequence, not the cause. And I mention this and we review this pretty often because I don't want people to think that they're special and different and unique from anyone else. You're all special, but you're not unique. You're all struggling with the same core issue, that is the consequence of whatever started this fire. You're struggling with the consequence of the fire. One more quick example just to give you how intrinsic this is in all of our bodies. Two examples, actually. There's an old experiment called the rubber hand trick to show you how your brain can be tricked into sensing things that are not there at that moment. There's an experiment where you can put a rubber hand in front of a person and they can see it. They take their hand and put it over here behind a curtain. And the experimenters rub both the rubber hand and their hand with a feather in synchrony, and the person begins to sense that that rubber hand is their hand because they see it and they can have the sensation. And to test this out, what the experimenters do after establishing that is they come over with a mallet and act like they're going to hit the rubber hand, and the person screams out, "Don't." And the person even knows what's happening, okay? The person even knows, that's not my hand, but their brain begins to sense that that's their hand. That's how vulnerable we are to this. And for you guys, much worse things have happened over a longer time. I just use that as a simple experiment. Another version is phantom pain. A limb could be lost, and yet the person's ankle still hurts. And we're all very familiar with that, but whatever's intact from the point of amputation on up still is sending the sensory pathway. That's what goes back to my earlier point. There's nothing to, you can't take care of the person's foot, the foot's gone. So central sensitization can happen in many varied forms for many different reasons. So that's the setup. So we talk in the program a lot about what we can actually do about this. And we have kind of highlighted the 4 reactive and maintaining factors: physical, emotional, behavioral, chemical. Before I do this, as long as I have the blue pen in my hand, I neglected to add in the motor cortex. This sits right next to the sensory cortex. There's an exact one-to-one correspondence by represented body parts in the motor cortex, just like the sensory one. And the reason I mention that is movement is controlled by the motor cortex. And so some of our patients can come in having central sensitization, but they also have movement-related issues, whether it's a tremor or a spasm or a repetitive movement. Some come in and actually have whole body episodes that look like epilepsy, but the brain's not misfiring, the motor cortex is in disarray, and it can lead to movement problems. So again, another condition that was previously thought to be a conversion or psychogenic is actually based in sensitization. So let's talk for a moment about these reactive and maintaining factors. I call them reactive and maintaining because at the beginning of the problem, some of the things you guys did made sense. If it hurts, don't do it. Let's rest it for a minute. Let's put some ice on it. Let's try to put a shot in there, whatever. And those factors at the beginning made sense to try, but now that it's become chronic, those same reactions now make the problem worse. This is the fuel to our fire. A couple of examples. Physically, rest kills. Too much rest leads to muscle atrophy, physical deconditioning, and unhealth. I've been in the medical, around medicine and hospitals for a very long time, and I can remember as a young man, I worked as a transportation aide, and doctors would admit patients for low back pain a week of bed rest with Valium and spinal traction. And at the end of the week, we would have to heavily assist that person into a wheelchair and heavily assist them into their car because they got weak in the week. Total joint patients would lay in bed for several days so they wouldn't dislocate their new joint, but they were weak when they got up to do physical therapy. Today, in hospitals, patients are walking after major surgery within hours of the surgery, okay? We used to think, well, let them rest and recover. No, it's let them get moving because rest kills. Deconditioning is very bad, and no one has ever rested their way out of central sensitization. Second issue, emotional. The emotional connections in the brain are the same connections that we have with our physical sensations and our memories. We implicate the limbic system a lot in this idea. You can't have a physical sensation without an emotional response. And in fact, all of our memories have an emotional tag on them. So even if you think about your pain, it can stir up emotional distress. And this becomes a two-way street. Every sensation adds to emotional distress. Emotional distress makes your sensations worse. And as I said a few minutes ago, it did not cause the problem, but stress and emotional distress is right there to jump on the bandwagon and add to the mix. That's why we spend so much time every week talking about stress management, anxiety management, depression management. Because as you can manage your mood and emotional state with cognitive behavior therapy, it can help your body. Didn't cause it, but it's definitely a player. Behavioral. Two major behavioral issues: pushing and crashing, and pain behaviors. Let me start with pain behaviors. Pain behaviors are those things a person says, does, or thinks that reminds themselves or others that they're having symptoms. Every pain behavior activates the circuit that we're trying to quiet down. Every thought, every comment, every emotion, every holding, every whatever you do in response to your symptoms adds fuel to the fire. And so much of the pain behaviors that our patients struggle with are invisible and insidious. Scanning, thinking about it, talking about it. And those things just worsen the pattern. They just worsen the pathway. We talked this week about an analogy of sensory memories and language. Some of the same kinds of receptor pathways are responsible for memory as well as sensory memory. And so when you think about your sensations, even if you're not having them, it's just like rehearsing a language. We're trying to help you not rehearse that so it's less accessible in some ways. Pushing and crashing is another behavioral pattern. Every time you felt better, you got up and did stuff because you felt good and you didn't know when you'd feel this good again and you had stuff to get done. You stirred up your symptoms and then you crashed. And every patient coming into the program is on that continuum of pushing and crashing. Some still can push quite a bit, others are mostly crashed out. But the inevitability is there will be a crash if we don't get pushing and crashing under control. And then chemistry. We'll talk a lot about this next week. The strong medicines, all the symptom treaters, pain pills, the benzodiazepine nerve pills, sleeping pills, some headache medicines, muscle relaxers, all these things that people take to control their symptoms actually end up controlling them. Your neurochemistry gets hijacked by these drugs. And it affects thinking, emotional functioning, physical functioning, digestive functioning, and it doesn't accomplish anything. It's just a temporary symptom Band-Aid. And then to kind of intertwine these for just a minute, some of you took symptom controlling medicines, took a pain pill, so you could vacuum the whole house before you crashed. So your drugs fed pushing and crashing. And then when you crashed, you got all ticked off at everybody because what is it? They don't see the dust bunnies under the couch? What is it? Live with a bunch of animals? And they don't even dare touch the vacuum because they won't vacuum as good as you vacuum. And then when you feel better, you go and vacuum to make everything fine again. And then you're mad at your people because they don't keep up with you. They don't dare touch the vacuum because you're going to criticize them. And every time you had energy, here's another emotional thing, just think about this. Every time you had energy, you didn't go work on your relationships. No one has ever told me, oh, you're wrong, Dr. Slutton. I just went and touched base with all the important people in my life when I had a good day. No, you didn't. You did stuff because there was stuff to be done. And the world was in disarray and you were going to make it all whole again. And then you crashed. And your people sat there and were like, what about us? So all of these things start to intertwine. That's what the whole program's about. So let me close with this analogy. An acute problem is like a house fire. If there's a house fire in a city, the city as a whole is relatively unimpacted, right? The neighborhood would be, the homeowners for sure would be. The fire department rolls in, puts a bunch of water on it, knocks down the fire, and then reconstruction begins. Chronic, when it becomes chronic, it is like a forest fire. The landscape is devastated. And even from far away, you can see the smoke or smell the smoke. Living in North Florida, last year we had the Okefenokee Swamp was on fire for weeks and weeks and weeks. You could walk out of your house in the morning and smell it and be miles away from it. This affects so much. And we treat forest fires very differently than we do house fires, don't we? You can't put just enough water on a forest fire or a raging wildfire. You have to starve it. You have to cut off the fuel supply. That's PRC. We're helping you starve the sensory fire. This is another hard concept because guess what? That takes time, it takes patience, it takes diligence, it takes hard work. It would be so much easier if we could just squirt something on it and make it go away. But it takes time to starve the fire. And you have to be all in on all four. This is another rule, not mine, it's just the rule. You can't pick and choose. This is not a Chinese menu. I'll have the Kung Pao chicken and a little lo mein, but no egg roll, please. You can't say, I'm going to exercise, I'm not going to do pain behaviors, I'll work on my emotional health, but I'm going to keep my medicines. You can't, non-negotiable. You can't say, you know what, I'm not too big into exercise, but I'll sure work on my stress management. It's not negotiable. You have to do all of it. And the really, really great news is that when people do all of it, the consequences are amazing. Sensations then have a chance to die down. And even when they don't, even when the sensations don't go away 100%, the quality of life improves tremendously. And so to reiterate a point I made earlier, and just to close with this, I'm going to use a case example from many, many years ago. I had a patient come through the program that had a thalamic stroke. This stroke knocked out their pain-controlling part of their brain. And this person lived 24/7, 365 with 8 to 10 out of 10 whole body burning pain. They described it to me like they felt like they were in boiling oil all the time. This person was depressed, drugged up, all the stuff. This person never had a chance, based on their physiologic damage, of having any reduction in symptoms. And yet, in my mind, they may be one of the best graduate stories ever because they took the program, they got reconditioned, they got off their medicines, their mood got better, and they went back to life. And if they're still alive, they're still in 8 to 10 out of 10 pain, but they're living life effectively. That's PRC. And I use that extreme example because all of the folks in the program right now and that we see for the majority of the time have a much better chance at symptom relief than that. But I can't let you have that be your focus. Your focus has to be on functioning. Your symptoms will follow. And the quicker you stop being preoccupied with your function or your feelings, and the quicker you get off the idea that somehow you have to feel better to function better, the better you'll do. Once you give that up and you start focusing on the 4 things you can do, that's great. Lastly, looking forward. After the program, these are the 4 areas that you can use as a diagnostic tool. If you feel like things are a little shaky down the road, look at the 4 areas. Have I gone back on strong medicines? How am I doing with my pain behaviors? How am I doing with moderation and my emotions? How am I doing with exercise? And usually by the time you answer those 4 questions, you're going to find the area you're slipping up in that you can readdress and get back on track. So this is not only a backward-looking model about what happened, this is a forward-looking model about what to do about it now and in the future. So this is the sensitization part of the class. This is where we talk about the model, and it has implications through the rest of the 3 weeks. All right, with that, we'll end now and move on to the next section, okay? All right. So we do have time for a few questions if there are anything anybody wants to ask. All right. Folks in the program can head back. Families stay in the area, and we'll be joined by the Team 1 folks.